Welcome to Mental Health Mini number 22 on Alzheimer's disease. Alzheimer's disease is a form of neurocognitive disorder and dementia and is the most common one in the United States. It affects about 10% of the population age 65 and older and does seem to affect women by 2/3. It is considered a primary neurocognitive disorder with a slow and insidious onset, although it is progressive and deteriorating. Prognosis is life expectancy of about 4 to 8 years after onset of symptoms. Risk factors for the development of Alzheimer's disease can be genetic related as well as age related. Diagnosis is often done during autopsy, so typically we'll diagnose someone based on symptoms, but it's rare to be able to confirm it during life. If individuals do have severe or early onset Alzheimer's, sometimes we can see some of the brain changes on a PET scan prior to death. We can do a microscopic analysis of brain tissue, especially in the hippocampus and cerebral cortex area. There's 3 different things that we see associated with Alzheimer's disease. The first thing that we see is neurofibrillary tangles, and these are supportive structure proteins that get tangled up and cause cell death. The cell death causes brain tissue death and shrinking. We also see amyloid beta plaques, which is a type of protein that deposits into the cells and causes the similar cell death. The third cause that we can see is an increase of tau proteins, and that works similarly as well. A CT or an MRI would show the brain degeneration due to those 3 causes, and this would have an atrophy of brain tissue, widening of the sulci, and enlarged ventricles. So you can see here in the picture on the left is a normal brain, and on the right is a brain with Alzheimer's. So you can see a lot of that tissue breakdown and shrinking of the tissue, the larger ventricles, and the widening sulci. Additional causes of Alzheimer's disease includes neurotransmitter changes, in particular a decrease in acetylcholine. It also impacts the way that dopamine, glutamate, serotonin, and norepinephrine works in the body. Alzheimer's disease can develop through head trauma, especially if that head trauma has led to an increased inflammatory response, because the increased inflammatory response leads to buildup of that amyloid beta plaques. Also, as I mentioned, we do see a genetic component with it, especially with APOE gene. We do also know that about 20 other genes may be involved, but the main gene will be that APOE. There are 6 or 7 different stages of Alzheimer's. Stage 1 is no symptoms. Stage 2 is very mild changes where they might have some short-term memory impairment. Stage 3 is mild cognitive decline that includes changes in thinking and reasoning, as well as impaired concentration and impaired organization. In stage 4, we see moderate cognitive decline, such as long-term memory loss, declining ADLs, confabulation, which is something where the individual will make up information to try and fill gaps in their memory. So they're not intentionally lying, they're just trying to fill in the spaces where they don't remember as clearly. We also see depression and social changes. Stage 5 is moderately severe cognitive decline, or the inability to independently perform ADLs, disorientation to place and time, frustration, withdrawal, and self-absorbed thinking. At this point, the individual is aware enough to know that they're starting to decline, and that can be very frustrating. So we may also see increased agitation at that point. Stage 6 is severe cognitive decline, where we see major memory loss, severe disorientation, no ability to perform ADLs, delusional thought content, psychomotor agitation, increased wandering, impaired use of language, and something we call sundowning phenomenon. And this is when the individual's symptoms get much more severe after the sun goes down. So during the day, they may seem clear and oriented, and then as soon as night rolls around, they may have an increase in symptoms. Stage 7 is very severe cognitive decline, and at this point, the individual is often bedridden, aphasic, and immobile. Care needs and treatment for individuals with Alzheimer's disease includes all of the ones that we talked about with typical neurocognitive disorders, but with Alzheimer's in particular, were very concerned for immobility and nutrition. With immobility, they may have the inability to move or use spasmodic movements. So this increases their risk for ulcers, injury, and falls. Our nursing interventions for this would be Q2 turns, range of motion activities, and medications to reduce muscle spasms and jerking. As far as nutrition goes, they may have lost interest in food, they may have lost memory as to when they last ate, or they may have dysphagia and impaired ability to hold utensils that may increase their risk of malnutrition as well as absorption. Our interventions for this would be to supervise their feedings, schedule their feedings for them so that they don't have that risk of not knowing when they last ate. And we have a variety of different specialized silverware that can help with any tremors or spastic movements so that they can keep the food on their utensil and eat it appropriately. And that wraps up our discussion on Alzheimer's disease.